I think we can begin. Today we have this huge pleasure to have this worldwide great host from Minneapolis Art Institute, Professor Brilakis, and we are talking about the new paper published on our intervention about the insight of perforation in a CTO from the Progress CTO registry. So I won't take any more time and I leave the stage to Manfredi, please.
So thank you, Pierre. And it's a great pleasure for me to be here this afternoon. I want to thank the GISE Young Group for the chance of presenting this paper in front of one of the giants in CTO PCI, which is Professor Brilakis. And so without any further delay, I'd like to start my presentation sort of setting the stage for why it's important to speak about complications and especially perforations in CTO PCI. So many papers actually sum up the fact that CTO PCI is associated with higher rates of complications, may it be MACE in general, death, myocardial infarction, the need for urgent CABG, and especially, as you can see from this graphic, perforation, which is a fourfold increase in the risk of perforation with CTO PCI. And adding to what I have just said, if we look at the Open CTO registry, we can see that among 9 deaths they had in the registry, all of them were associated with a perforation. So definitely perforations impact a lot on procedural and clinical outcomes. And just to put into frame further discussion, we have to sort of classify perforations. And one classification we can do is we can classify perforations based on location. So either main vessel perforation or distal wire perforation, which are common to everyday PCI, or else collateral perforation, may it be septal or epicardial, which is specific for CTO PCI and especially retrograde CTO PCI. And then we obviously have a severity classification through the Ellis historical classification, where basically perforations which are actually clinically meaningful are type 2 and type 3, while step 1 is more of a really, really bad dissection, basically. And turning to the paper from the Progress CTO registry in January 2023 this year, Konstantinis and his co-authors presented a score which is sort of useful to predict the risk of having a perforation. So it's the Progress CTO perforation score published in Error Intervention. The patient population is 9,618 CTO PCIs performed or attempted between 2012 and 2021 at 38 centers worldwide, most of them in the United States. It's an online database, and the exclusion criteria were patients who had a second CTO PCI during the study period, or procedures which were lacking data on technical success, procedural success, or peri-procedural complications. So starting to dive into the paper, the first thing we can stress out is that the actual rate of perforation amongst the study population was quite low, ranging at around 3.8%. And in looking at the different clinical, angiographic, and procedural characteristics on univariable logistic regression, several of them were associated with statistical significance, mainly age, prior CABG, right coronary artery CTO, moderate to severe calcification, moderate to severe proximal vessel tortuosity, proximal cap ambiguity, and a blunt stampless proximal cap, ADR use, and the use of the retrograde approach. Starting from these variables, which were statistically significant on univariable regression, they were included in a multivariable logistic regression with backward elimination. And from this analysis, the actual score and the actual factors associated with the risk of having a perforation, which were significant and multivariate analysis, were derived. And these are 5 factors: age, which was dichotomized in over or under 65 years old, the use of antegrade dissection and reentry, the use of the retrograde technique, moderate or severe calcification, and the CTO, which was blunt or no stamp at the proximal cap. And obviously, different odds ratio were derived based on the impact of these single parameters. And we can see as the highest odds ratio was for the use of antegrade dissection and reentry and the use of the retrograde technique, which maybe will deserve a discussion further on because, as you can imagine, these are more advanced techniques compared with antegrade wire escalation. And the score was derived by basically assigning weighted points to the beta coefficients of the multivariate analysis. So a score of 1 was attributed to all the parameters except for the retrograde procedure. And after having obtained the score, an internal validation was performed with bootstrapping method, and the ROC analysis showed an acceptable correlation with an area under the curve of 0.74. And this is true even if we look at the single different types of perforation. I mean, main vessel perforation or collateral perforation or distal wire perforation. The only association that was less strong was that with septal perforations. And when we put all these data together, we obtain a score between 0 and 5, which corresponds to a risk of having a perforation that ranges between 0.7% and 11.2%. And we can see as the patients in the registry actually clustered around the progress CTO score for perforation of 1 and 2. And turning to the perforation characteristics, this is quite interesting. Most of the perforations in the registry were actually large vessel perforations. And the crossing strategy that actually caused the perforation was more often antegrade wiring or retrograde wiring. Perforation severity was more or less balanced through the Ellis classification. And if we look at the supplementary table 3, when we look at the perforation type according to the crossing strategy, it's interesting to notice that specifically for retrograde procedures, 56% of perforations were in collateral channels, septals or epicardial. It's quite obvious that these perforations are sort of only in retrograde procedures, obviously, and they account for 56% of the perforations in that setting. And what about, again, technical and procedural success? What does this imply, having a perforation? Well, both technical and procedural success rates were lower among cases where a perforation happened. And patients with perforations more often required a left ventricular assist device and had longer stay after CTO PCI, which is obviously relevant on outcomes. Also because the incidence of MACE was higher in perforations case, 21% versus 1.4%. So we can see how, apart from the fact of complicating the procedure per se, also the procedural success intending the stay in hospital free of MACE was impacted by having a perforation. And are there any other scores we can compare the progress CTO perforation score with? They are, and the one score that's available is the open clean perforation score derived from the Open CTO registry, which is a registry of 12 experienced United States centers on 1,000 patients, and they derived, once again, 5 variables that make up the open clean perforation score. But this is quite interesting, and maybe we can discuss about this later. The variables that are actually in common are few, only age and the presence of calcification. And we can see once again how by increasing the open clean score for perforation, basically the risk goes up. And ending up this slide, it's interesting to see how there has been an external validation of the open clean score applied to a CTO cohort of patients, and the correlation was 0.62, which wasn't actually that high. So that's interesting, and we can discuss about this. I mean, in the paper, the authors say that probably applying the risk model to a different cohort and having different results means and reflects difference in practice. And to end up our discussion, paper prompted an editorial by Sianos, which I mean, I invite everybody to read because I found it quite interesting in the sense that it was a little bit polemic. It was as if, it seemed as if the paper, in Sianos' opinion, obviously, wanted to discourage the use of retrograde or more advanced techniques. But in my opinion, this is not the point. And turning to conclusions and perspectives, perforations are feared and impacting complication, as we saw through the data. And these were scored, both of the Progress CTO perforation score and the Open Clean score, together and mixing them up with scores which reflect technical complexity, for instance, the JCTO score. I mean, they're not orienting practice, but they can help risk stratify patients. And this in turn can inform the operator of what could be expected throughout the procedure. So what are the risks? What are the implications? So basically, to summarize it up, be aware and be prepared when you have high risk score for a perforation, and basically be equipped too. So to end up with a citation from the Untouchables, don't show up to a gunfight with a knife. Thank you.
Thank you. Well done, Manfredi. Really brilliant presentation. And now we go ahead into this discussion. So I invite Professor Brilakis to a starting comment about the paper.
Yeah, thank you. And first of all, congratulations, Manfredi. Great work on summarizing the article and the information included in that. And I think that was very global and very well done. Maybe actually I can ask you, how many of you do use, and I know it's early in your career, obviously, because you're still training, but how many of you are using scores of any kind for any kind of PCI, CTO or otherwise?
We can do it by raising your hand through the chat if you want.
Yeah, well, I can answer just 1 second, Pierre, in saying that I use scores mainly for CTO PCI, to be honest, and not that much for ordinary PCI. And it's quite obvious that the most used score is the JCTO score, which basically helps us stratify the complexity, as I said. I mean, JCTO is how many, for who doesn't know it, it's the, it basically correlates with the chance of wiring a CTO within 30 minutes. So as the score goes up, basically the complexity goes up. So I use scores mainly in CTO PCI, not in everyday PCI, to be honest.
Yeah, absolutely. And actually, here's my take on this. Every procedure we do, whether it's intervention, structural, coronary, surgery, whatever you do, there's always a benefit and a risk, right? And the question is, how much is the benefit and how much is the risk? And clinical experience is, of course, very, very important. I mean, clinical experience is different because the reality is all the scores are averages, right? And some operators are more successful than others, and more so some operators are more dangerous than others. So, but you need two things. You need what's the benefit and what's the risk. And I think having the scores of this kind, like the risk scores, like this, the perforation score we're discussing today, there's other complication scores, gives you an estimate for the risk. So you can tell the patient, look, you're going to have this procedure, your risk of having death or having a major problem is going to be 1, 2, 3, 4, 5%. So I think that helps both the operator and the patient make some more informed decision. And then based on the JCTO, as you mentioned, you say, okay, success is going to be 85% or something. And then you can say, look, you have 85% being successful, potentially helping with your symptoms. you have 3 or 4 or 5% risk of a complication. What do you want us to do? You want us to do the procedure or not? And I think that gives you the whole balance. It's by no means perfect, as I think Manfredi alluded very nicely. There's no perfect score. And as you know, different operators, different hospitals, they have different, it's not the same, but at the same time, it's something to start with. And for me, a benefit is not necessarily you get the 3% or 4%, that's useful, but it's also, it forces you to look at the parameters. You look at the angiogram and say, okay, do I have this ambiguous cup? Do I have a blunt stump? Do I have calcium? Helps you actually look at the angiogram and at the patient in a little more critical way and understand better what is going on.
As you notice, we have connected also Professor Colombo, Professor Di Mario, and Dr. Tumschitz from Ferrara. So if you have any question from this great audience today, please take the stage. And I want also to...
Sorry, can I ask, Manos, if you could tell me something about your thought about post-CABG patients, which seems to be the most tough situation you face in nowadays, considering the risk.
Yeah, absolutely. As you know, we used to think that bypass patients are protected. First of all, they're more complex, right? They're going to be older, they have more comorbidities, they have more calcium, they have more complex lesions because the distal cap is usually harder because of the systemic pressure being exposed to that. So, they're much more complex patients. But when it comes specifically for the perforation situation, we used to think that because of the adhesions of the pericardium, you're less likely to get tamponade. And we learned, actually, open CTO was very important in that. We learned that actually, if you perforate in a bypass patient, not always, but sometimes you may get these loculated hematomas, compressing chambers and causing cardiogenic shock that can be very, very hard to treat. Because a standard perforation, you put a pericardial drain, you drain the blood. But if you have a loculated effusion, quite often you cannot drain it unless you go to a CAT scan guidance or you go to emergency cardiac surgery. And emergency surgery in a patient who has bypass already, that's a disaster. Ask any surgeon, just to go in, fix the adhesions, get to the heart takes for a long, long time, which is a problem in a catastrophic complication like this. So now for me, the lesson is, and I've had a death in patients like this, and the open CTO deaths were mostly in these patients, is if you have a perforation in a bypass patient, you want to be extremely quick to take care of it. Put a covered stent, put a coil, whatever. You don't want to let any perforation dwindle there, because if a loculated hematoma happens, that can be literally a lethal complication for the patient.
Thank you. Very good message to take home. Thank you.
So we have some question from the audience. Rossella is asking us, can you give us some practical advice on how to deal with perforations during CTO treatment?
Perfect. And complications can be stressful for everyone, as you know. And in my mind, the key thing is to have in your mind the steps. And the one thing, if you're going to remember one step, this is to put a balloon up as quickly as you can. And also make sure the balloon is working, because it happened to all of us. You put a balloon up, you say, okay, I'm good now. And then you take a picture 2 minutes later, you realize the balloon is not big enough, or you're still leaking around the balloon, or there's some retrograde bleeding. So make sure that you put the balloon up and take a picture to make a scene to make sure that there is no bleeding around the balloon. So you still the perforation is covered. So that gives you time to breathe, right? You have now the perforation, you have the balloon, so there is no active bleeding in the pericardium. And actually, if you do this quickly, you may not need to do a pericardiocentesis, because that prevents blood in the pericardium, and then you have much less problems than you would have otherwise. So that's the first step. Always put a balloon up and then take care of it. And then the second decision is whether you're going to need to put a covered stent or embolize. And that depends on the type of perforation. And the type of perforation is, if it's a large vessel, usually it's a covered stent. If it's a distal vessel or a collateral, it's going to be embolization. Now, the cover stent is straightforward in a way, right? You put a cover stent. Typically, you do the single or dual guide catheter. You want to prevent the blood, so the balloon is up until the moment that the cover stand goes in and gets deployed. But then for the coiling, many people, and not just in training, but many seasoned interventionalists, because you don't have this very often, right? You don't do coiling very often in the cath lab because we're not interventional radiologists. So the problem that happened to me and many other people is that you now have to put a coil in and you've never done it, or you've done it once in your life. So you have the stress of how do I put the coil in and how does that work? So what I strongly recommend that you do, we do this with our fellows all the time, is ask one of the device reps, whichever coils you have in your lab, whether it's Terumo, Medtronic, whichever you have them come to your lab and have you deploy a couple coils yourself on a bench model. I mean, it's very simple. It's not a rocket science, but unless you've done it, it's much more stressful because learning how to deploy a coil at the time of perforation, the patient may be unstable, you're in a time crunch, it's much more stressful. So what I would suggest is you ask them to come to your lab, have you play with a couple of coils, deploy them, see how they're detachable, and then that gives you much better comfort to deal with the complication if and when it arrives.
Thank you. And we have two more questions from Eric. And the first one is, how is the risk score impacting your daily clinical practice? And the second one, is the use of the score decreasing your number of CTO procedures per year because of the shared decision-making with the patient you described?
Yeah, thank you. Great points. And what we typically do is calculate both a success and a complications score. And actually, the perforation is perforation is more for the operator. I think for the patient doesn't really care that much. I mean, he cares, is he going to get, a heart attack? Is she going to die? Is she going to have to go to emergency surgery, get a stroke? I think the patient doesn't really care. I think the perforation is more technical for us. But what we do is we calculate a success score, JCTO most commonly. There's a progress too, but the JCTO is the most commonly used. And then we calculate the complication score. So we tell the patient, look, you have 85% success for success chance, and you have about 3.5%, whatever it is, risk of having a complication. These are the complications: death, heart attack, stroke. The big ones are going to be, again, those death, heart attack, stroke, emergency bypass. And then discuss with the patient, okay, how much angina do you have? If you're having a lot of angina or angina equivalents, then is it worth going through this? If the patient has mild symptoms, has a super high risk of complications, sometimes you tell them, look, it's not worth it. The risk of doing this in an 85-year-old person with previous bypass and mild angina, you should have really, this is not a good indication to go in because the benefit is low and the risk is high. Conversely, a patient who is 40 years old, has class 4 angina, and has a 2% risk, the benefit there is much more and the risk is much less. So then it's much more clear decision making. But as I mentioned, a lot of these things, you can do the score, it can be more accurate on a patient basis, but also you can give them the average numbers. So for both Europe and US and most countries, success these days is between 85 and 90% at good centers who are experienced in doing this. And then the complication rate is about 2 to 3% is the average complication rate. So even if you don't want to do this full exercise for every specific patient, you give them the average numbers for the whole cohort of patients that have this.
Thank you. And the question from Alessandro Beneduce is about how to deal, maybe also psychologically, with a large perforation occurring before CTO wire crossing.
Yeah, so for most, in most time, if you have a major complication, you stop the procedure, right? Because the goal here is safety. You had a major perforation, you should not, try to continue to open the CTO because you have to, go give heparin. Even if you, let's say, have perforation, right? Then you take care of it. You perforate a large vessel, but you put the cover stand and now it's okay. You should not go on and do the procedure because, heparin may bleed again. Who knows? And the patient may have an effusion, may become hemodynamically unstable. So in 99% of the time, if you have a perforation or any major complication, you stop the case unless you need to do something to take care of the complication. Now, there are a few cases where actually continuing with the case may work. So, for example, there are cases where you go to cross and you perforate undergrade. And now you have a balloon up, no much effusion, but you don't want to put coils there because then you'll make it much harder to open it later on. So if you're a very experienced operator and the patient is very stable, what has been done is go retrograde if you have a good option, dissect, and then use the dissection tissue to kind of tamponade that perforation and seal the perforation. But again, these are the exceptions to the rule. For most intents and purposes, if you have a perforation or a complication, you take care of the problem, get out. And then you can always go back and do whatever, but don't try to be a hero because bad things, one thing brings another. You have a complication, then you bring another complication, and then things can get worse.
Yes, and thank you for this insight of our vision, because the audience is formed by interventional young cardiologists, and that's my question about, since the last downgrading of the in class 2B of the American guidelines, what do you think? What is your idea about the future direction and education, formation of young interventional cardiologists that are approaching to CTO procedure?
Yeah, great point, and thanks for bringing it up. As people know, in the American guidelines, the HACC, CTO has a 2B indication for relieving symptoms, and they gave that indication because EuroCTO trial was positive in relieving symptoms more than medical therapy, but Decision CTO, which was a Korean study with some limitations, but nevertheless did not show any significant difference in symptoms. And it's possible that the new European guidelines coming out might actually come to the same recommendation. Well, here is my take, and obviously I'm biased because I do a lot of CTO procedures, but most of the patients we do are patients with severe symptoms. And those patients, they have a very poor quality of life, and they do need to have something done, whether it's surgery, whether it's CTO intervention. So it's not for everyone, obviously, but despite the guideline recommendation, there are still many, many patients who have a strong indication for getting this done. Now, on your side, if you decide to become a CTO operator, there are good things and bad things. The good things is, it's a very intellectually stimulating. It's still growing. There is not as many people doing this. So unlike other things like structural, at least in the US, or peripheral, not as many people do CTO. And this is the good and the bad news. The bad news is this is not a easy way to make your living, right? As you probably have seen, these are cases you have more complications, can be very stressful. You can spend 2, 3, 4 hours and still fail. There is a longer learning curve. At the same time, again, it's something that I think will be in need. And what we're seeing in the US and potentially may happen in Europe as well is that there is saturation in terms of structural interventionalists right now. There is no jobs for interventionalists who do structural, but for complex coronary and CTO, and again, CTO is a major part of the complex coronary or chip operator, there's a lot of demand. Plus, it makes you a better operator in many other ways. Do your STEMIs, you may have issues with visualization. The CTO techniques can help you a lot. You get familiar with dealing with complications. So you're much more successful and able to deal with things that otherwise might phase you out. So it is something appealing. I think there will be a clinical need going down, but it's going to be challenging. It takes a long time to learn, and it's a stressful job.
So what's for you is the best attitude for this kind of job, in your opinion?
Well, it's something that you understand what you control and you don't control. I love to talk about the Stoic principles and, obviously Italy and a lot of Stoic philosophy, which I think may be going on the daily life. But the bottom line is in CTO, there are things you control and things you don't control. The success of the case, you don't control. You only partially control it. You can do the best you can, study the angiogram, plan carefully, understand the techniques, use the right equipment. But end of the day, even in the best operators, as you've seen in live cases, in all the meetings, bad things happen, failures happen. So when you come prepared that, look, I'll do my best, but there's a possibility I will fail or a possibility I will have a complication, and you explain this to the patient and you make sure everyone is on the same page, then I think you'll do great and you'll still be much more successful. But if you put your personal worth on the line and say, look, if I don't succeed here, that means I'm a bad person or a bad interventionist, that's how things become very tough, because the reality is no one is perfect. And especially in this business, you're going to have bad outcomes happen as well. So understanding your limitations, being humble about them, and explain to the patients that, hey, we'll do our best, but may not work and complications may happen. I think that's the best attitude for feeling better about it and also being more successful. I think if you're super stressed out and you feel I have to be 100% success, what we've seen in the past is the more you try to make the success the end of it and you forget about complications, your complication rate goes up. So trying to make the balance, sometimes it's better to fail and not have a complication than to persist and go through this epicardial collateral and perforate and have a major complication. That's not the best interest of the patient or yourself. So having this into perspective, it's a very hard job. I'm learning still how to get this in perspective, but this is, I think, the best way to think of this.
So thank you for this great teaching. I think we had a great discussion today, and I want to thank you, Professor Brilakis, from all the GISE group and the MCH group. And we will see in 2 weeks, and then I thank you again, and thank you also to Manfredi, and see you. This is the end of this Journal Club. Bye.
Wonderful. Thanks again. Thanks so much.
Thank you.
Thank you.